Good day, and welcome to another episode of Living Well with Adena. My name is Dr. Kataka, and I'll serve as your host today. Thank you for joining us. We want to hear from you, so at any time if you have questions or comments, please be sure to leave them in the box below. We have staff that are on standby and ready to be able to assist us in getting those questions answered for you. Today we're going to be talking about cancer, which actually affects about 1 in every 3 Americans. Matter of fact, it's the leading cause of death only after heart disease. Cancer is a complex problem sometimes that can affect different parts of the body, including the lungs, the breast, the colon, or even the blood. For most people, cancer can be treated successfully, and that's even more important if it's caught early. You don't have to face this diagnosis alone, and we're very fortunate at Adena Health System to have a robust cancer center where you can receive patient-centered cancer care all under one roof. We're very fortunate to be joined by 2 guests today that I'm going to introduce to you right now. The first one is Dr. Alex Wilson, who's a radiation oncologist and the medical director at Adena Cancer Center. And today we're also joined by Tammy McManus, who is the lung and prostate cancer patient navigator. Welcome to both of you.
Thank you.
We're glad that you're here. So Dr. Wilson, if you can please tell us more about yourself and where you're from and a little bit about your background.
Yes, so I'm Alex Wilson. I'm a radiation oncologist. I'm from Carlisle, Kentucky, which is a town of about 1,800 people just south of Maysville, Kentucky, if you know where that is. I'm trained at University of Kentucky for medical school and residency training, and then started working here at Adena.
Fantastic. Welcome. And Tammy, tell us a little bit about yourself so the audience can get to know you as well.
Yeah, my name's Tammy McManus. I'm born and raised in Pike County, but now I live in Jackson County since I've been married. Been married for 37 years to my husband, Randy. And I've always worked at Adena. That's really the only job that I've had since I've been a nurse. I've been here for 41 years, and 36 of those have been with cancer care, and I've really loved it. And my background as far as education, I got my ADN in nursing from Shawnee State University and my bachelor's from Ohio University. And I have 2 certifications, one in oncology nursing certification, and then the other's with oncology nurse navigator certified generalist.
Welcome, Tammy, and thank you for being with us today.
Thank you.
And we certainly appreciate your depth of knowledge, and we're looking forward to hearing more about how that plays out in the Cancer Center.
Sure.
Dr. Wilson, this might be a great time for us to start with just the general question, right? What is cancer? Perhaps most people understand that, but for those of you that may not, give us some clarity around how you approach that and how you define it.
It can be fairly confusing, particularly if you're in the hospital or you see a doctor and they say, oh, I found a growth or a lesion or a tumor, what those words kind of mean. In essence, cancer itself is unregulated cell growth. So it's cells that have become abnormal. They tend to grow and spread throughout the body or locally, and your body can't take care of them. So the immune system is too much for them. So cancer has ways of evading your immune system. So essentially, if your doctor talks to you and they say, we did a CAT scan, I see a lesion, I see a tumor, you don't know for sure if it's cancer unless you've done a biopsy, typically. And almost 100% of cancers, a biopsy is required for treatment and for diagnosis. So essentially, what a doctor sees on a scan often may be worrisome for cancer, but it can't be really defined as that unless you've had a biopsy.
Okay, so let's talk a little bit about that word you used, biopsy. So can you help us understand what that means?
Yeah, so they take a sample of the tumor. So there's different ways to do that. Sometimes you take a sample of the tumor by going ahead and having surgery. Sometimes they put a small needle into the tumor with looking through a CAT scan. But it's just a way of getting a sample. So there's multiple different ways of doing that.
Should patients that are instructed to get a biopsy, should they be afraid of that?
I don't think there's any reason to be afraid of a biopsy. When a doctor talks to you about that word, it's a scary word. I think many people associate that too with the results, worry and fear about potential worrisome or bad results. But the biopsy itself, before you do it, the doctor would talk to you and explain to you exactly how that would be done. often send you to a physician who does that procedure, talk about the risks and benefits, and often there's more than one way to do a biopsy. So sometimes I'll have patients that prefer one way versus another, and we can work with that patient to get the biopsy how they're more comfortable.
Dr. Wilson, you mentioned to us what cancer is. Can you talk to those of us, to the audience, a little bit about what causes some of that changes in cells then? What's the mechanism? Why did it happen?
Mm-hmm. So a very small proportion of cancers are due to genetic changes in your family. And as far as you know, it's less than 5% of cancers. Most cancers we think are due to some type of exposure, but oftentimes we don't know what we're exposed to. You know, a lot of times, particularly even at work many years ago, workplaces weren't very forthcoming about the exposures in the workplace. Or in your home, we discover things that can cause cancer over the years, and now we avoid them, but perhaps we didn't know about it back then, and then there are things probably we're exposed to now that we don't know could cause cancer that we may learn in the future cause cancer. So essentially it's often difficult to tell. Smoking is definitely something that's pointed to often, and it does increase the risk for many cancers. Alcohol use can increase the risk for many cancers. Smoking in particular with lung cancer, cancers of the head and neck, bladder cancer. There's some pretty strong associations there, but as we all know, not everyone that smokes gets cancer. There's more to it than that. There's predisposition likely genetically that we don't understand as well.
Is it also true that some people who never smoke can get lung cancer?
That's correct. Yeah. So there are known exposures in this area, gas called radon in the home that folks can get exposed to. But in general, yes, anyone can get cancer, and it's an interaction of your genetics and your exposures. And it's very difficult for a doctor or anyone to pin down exactly why one person got cancer. There are very limited instances where we can do that.
Thank you, Dr. Wilson. We'll turn our attention to Tammy here for just a moment.
Mm-hmm.
So Tammy, we're going to talk a little bit later on the program about cancers, various treatments, and how you work as a patient-centered team. But ideally, we should try to avoid getting cancer to begin with.
Mm-hmm.
Can you tell our audience and talk to us a little bit about what are some ways to reduce our cancer risk?
Yes. Well, a lot of things are just pretty much common sense that have been stressed to us all along. You know, get and stay at a healthy weight. Number one, too, you want to have a family doctor. I know there are some people that come to us that don't have like a primary care physician is what I'm trying to say. And so it's important to have one to begin with and get regular checkups too so you can catch things early.
And that is key, right?
Yes,
Getting
that's key.
that early detection.
Right, absolutely.
Okay.
Yes, it is. And regular exercise, of course, which a lot of us don't do, but we should. At least 30 minutes, 5 days a week is kind of ideal, or at least 3. You also want to, if you drink alcohol, in moderation is best. They recommend for women only 1 drink a day, men 2 at the most. And it's probably actually best to abstain if you can. But and also what Dr. Wilson mentioned, tobacco, and that's a heavy thing in this area. A lot of people start at a very young age, and it's just kind of something that everybody in their family does, so they have done it.
Now, Tammy, is that
yeah.
all forms of tobacco?
Yes,
Okay.
yes. Yeah, some people think they can quit, you know, cigarettes and, well, I'll just go to chewing or snuff. Those things also are very dangerous because they can cause head and neck cancers and things like that. So, you know, you want to avoid those also. What else?
So Tammy,
I think
what
we mentioned
about
most of it.
skin cancer? How can we protect ourselves against skin
Yes,
cancer?
absolutely. We need to wear sunscreen when you're out. Really, a person, you know, should put it on every day after you take your shower or whatever. If you are out in the sun, you want to particularly wear coverings, you know, like hats, coverings over your arms and things like that. Be out, if you're out in the midday sun, that's a particularly hard time to be out for your skin, so you need to, you know, kind of avoid the heavy hours of sun, which would be anywhere now from probably 10 or 11 a.m. until at least 2 or 3. And just common sense type things like that.
Sure. And is it important to protect our skin even in the winter times when
Yes,
we're not
it
out
is.
swimming? And
Still, there are ultraviolet rays, that can affect your skin. So particularly, a lot of people's face, if you're fair-skinned, can be a problem. So, and there again, you need to check with your doctor and have them, if there's a mole or a certain place on you that you worry about, looks like it's changed or whatever, draw it to their attention quickly. And
because some of those can be serious, right, Dr.
Yeah.
Wilson, as far as skin cancers?
That's right. And sometimes it's kind of hard to tell which ones might be serious versus not. So it is important to look at your skin, to have a primary care doctor that will help you look at your skin. But if you do see something, it's good to bring someone's attention. It's also good to pay attention to it, make sure it's not growing, make sure it's not changing color, shape, size. If you can't get to the doctor quickly, if it's growing or changing color, you might need to go sooner rather than later, make it more of an emergency or urgent type of visit.
Don't go at it alone.
Right.
Yeah.
Mm-hmm.
Now, Dr. Wilson, Tammy mentioned some screenings. What would be some screenings that would be important for folks to undergo or understand? Or Tammy, if you want to weigh in on that as well.
Yeah, so breast mammography is one recommended for ladies.
So mammograms,
right. Mammograms, colonoscopies, pap smears, skin exams we just mentioned.
Right.
PSA is a lab test that your doctor can do for prostate cancer as a screening exam. That is a discussion you should have with your primary doctor about whether that's right for you. And then we do have a lung cancer screening program that scans folks typically once a year. It's completely free here at Adena. And that helps detect lung cancer at a very early stage. Very important for this area. We just have a very high incidence of lung cancer. It's an important one to highlight.
All right, and I think I'll do that right now, actually. So as Dr. Wilson mentioned, Adena does have a lung cancer screening that is available all year round. I want to let the viewers know about a special screening event here at Adena, which will be in recognition of Lung Cancer Awareness Month. And it's going to be held on Saturday, November 21st. So again, that's Saturday, November 21st from 8 a.m. to noon. And there's a specific group of our viewers that would be eligible for this screening. People should be between 55 and 74. So if you're in that age group, hopefully your ears are perking up, or if you know someone in that age group. And if that person or patient has had more than 30 pack years of smoking in their past. So an easy way to calculate that is if you've smoked one pack a day for 30 years, that's 1 times 30, you would qualify. But if you're a 2-pack a day, then that's 15 years worth, which equals 30. So however you do that math. Participants should also be a current smoker, will help you quit, or someone who has quit smoking in the last 15 years. So again, that criteria, if you're between the ages of 55 and 74, if you've had 30 or more what we call pack years of smoking, and that you either are a current smoker or that you've quit smoking in the past 15 years. Love for you to take advantage of that screening. Because again, right, Dr. Wilson and Tammy, if it's caught earlier, the successes are better, or the outcomes can be better with the earlier detection.
Absolutely.
All right, fantastic. Dr. Wilson, so we've talked about what is cancer, and Tammy, you've talked to us greatly about how to prevent that. But even if we do our best, life happens, and as I mentioned earlier in the program, 1 out of 3 Americans will have cancer or potentially have cancer in their life. What happens? What's the first thing that happens when someone finds out they have cancer? They come to you and walk the viewer through what might be a very challenging time.
So typically, as we mentioned earlier, kind of goes back to what we were talking about earlier, when so doctor often will notice you'll have a lesion or something abnormal on an x-ray or a CAT scan, either based on a symptom you're having or based on a scan you had for other reasons. And then there's a time and period there where you're not sure if you have cancer or not. And then some type of biopsy is arranged. At that point, usually then you'll meet me at the cancer center or one of our oncologists. And that's a kind of a difficult time because it's a lot of unknown. It's a scary time, and so what we try to do is when we get a cancer diagnosis, I kind of review the case and we make sure we get everybody involved kind of as quickly as we can, and what that actually does is it helps with patients cope with the experience, because it's just such a scary, uncertain time. So getting people to plan together with lots of input from lots of people really helps. The thing about cancer is often you don't just treat it with one thing. So you need a multidisciplinary or many different types of doctors to work on that for you. And then you often need additional tests, so that you need scans, labs, things like that. And so there's another period there after you kind of know, oh, I have a cancer, I know what kind it is, and you kind of figure out, like, where is it? How bad is it? Is it gone anywhere else? And then once we know that, we can settle on a treatment plan. And when we start to settle on a treatment plan, here at Adena and many cancer centers across the country, we sit down in a room with a group of multidisciplinary specialists. So you have one that looks at the CAT scans, a radiologist. You have one that looks at the biopsy, the pathologist. You have radiation doctors like me, chemotherapy doctors, surgeons, and we all sit in the same room, talk about how things look, what it is, where it is, and how we plan to attack it, and make sure we come to some sort of agreement on that, and compare that toward national guidelines and national standards. And then we can relay that plan to our patients and help you get through it. And all during that time, we have folks like Tammy and social workers and financial counselors and pastoral care kind of helping through that journey, because it's about a lot more than the scans and the stage and the type. Mm-hmm. It's also about just trying to make it through that period of time and get mentally ready to kind of approach the cancer as it needs to be done.
You're really describing a very robust team approach, mm-hmm. right? It's the patients in your description don't see just one doctor, they potentially see more than one. Mm-hmm. And then you just mentioned for Tammy here, mm-hmm. That a lot of patients will be connected to Tammy. Tammy, this would be a great time, I think, to help the viewers understand the role of what a nurse navigator does, or what does it mean to be navigated?
Yes. A lot of times when patients just hear the word cancer, it's almost just like, it puts you in a state of shock a little bit, or a lot, and you can't think, like, what do I do next? Who do I turn to? The doctor may tell you what's going on, and sometimes they don't even understand or comprehend because they're just so overwhelmed. So the role of the nurse navigator, we follow the patients really from the time that we have a diagnosis through treatment, throughout whatever they have to do as far as getting treated. And we even contact them beforehand, before they come to see us, so that they have a familiar face and name. We call them on the phone, we introduce ourselves, we tell them who we are as far as what we do, that we're there to help them, that we're a point person to answer questions. That's the main thing, I think, is education piece with patients. You need to know the treatment plan and beforehand, of course, all of the things that they need to go through as far as the testing. We help set that up, and we try to watch that it's done in a timely manner, that nothing's missed, and if it is, we try to catch that, correct it, and keep moving forward. Communication is key too. We need to talk, like with Dr. Wilson, with his partner Dr. Thompson, and with all the medical oncologists and just all the people. We're kind of a collaborative effort as far as working with everybody on the team to kind of pull everyone together and for the patient. So that's mainly what we do. And there are 6 navigators, and that's quite a lot for our size of hospital too. In like national meetings and places that I've been, they're like, you have that many navigators? And we're yeah, so it's great to have that many. I deal with lung and prostate, and I have a partner, Ashley, that helps me with that. And then we have 2 people that do breast and women's gynecological cancers, and then another 2 navigators, Barbara Short and Gina Fields, that deal with pretty much everything else, the GI, brain, anything hematological and that type thing. So.
You mentioned that patients often have questions.
Yes.
What are some common questions that you tackle?
Well, they'll ask us a lot of times, what the treatment plan is. And a big question they'll come up with a lot of times is, how long do I have, and that kind of thing. And which we pretty much, it's difficult to answer that. We tell them, in conjunction with the doctor and with all the team, we just go forward and we're treating you and we're going to do the best we can for you. And many times we can have some cures with some of the cancers if they're found early enough. So
Dr. Wilson, in your experience with a nurse navigator, could you be a successful oncologist without one?
No, I wouldn't call myself a success without my nurse navigators or my nurses. There's no way, because the thing is, we're not available enough to the patients. Patients have so many needs and so many questions, and what would really upset me is if I were a patient, every time I called in I had to wait for the phone tree, and I'm calling every day and they're sending me to different people and different voicemails. And what the navigator does for folks is it gives them a phone number they can call every day, and that way if they need anything they can find the right person. Because I just mentioned earlier, you got a surgeon, you got a radiation doctor, a chemo doctor, somebody did the biopsy, you're in the hospital, you had that doctor. Who do you turn to if you just need a prescription filled? You can ask Tammy, and Tammy can get the right person involved and get that to you. It's kind of magical, really.
Pretty fast. Pretty fast.
Because it's kind of a difficult thing for someone to do on their own with that many moving parts. So, no, I think we need our nursing team, in particular navigators, to be a success.
Tammy, sometimes patients will have significant challenges. Their diagnosis or their cancer treatment might interfere with their ability to work. It might interfere with their schooling or ability to care for others. Do you also provide mechanisms or help with social challenges or getting resources for patients? And if so, what does that look like?
Absolutely. Yes, we do the, as far as work goes, the FMLA paperwork, we complete that for the patients so that they can, many of them will still continue working through treatment, and they're able to do that. So we feel, complete the paperwork as far as to their ability, if they're able to intermittently work, or, if they need to be off a period of time, then we have our physicians to look it over and sign it and approve of it. And of course, we also refer people to social services and that type of thing when they're having problems, also with transportation. We can help with that too through different avenues that we have. But we have social workers, we have financial counselors. A lot of times, many of the cancer, the oral medications are quite expensive, and we work with the companies and our financial counselor that we have at the cancer center to get them help with. Many times they don't have any copay at all. So it's based on your how much that you make and your need. So just many things that we do. We do a lot of things on the telephone as far as communicating with the patients when they're on treatment. We try to talk with them a day or a couple of days after their treatment to see how they're doing. If there's any need, we try to jump on that, and like Dr. Wilson said, if there's any prescriptions that they don't have, we are a liaison with the doctor to try to get those for them. And just any questions that they have. Sometimes they, even though you give them all this education, and we do have a session too where we, it's called the big name leaves me right now, but it's an educational session that we sit with the patients, go over all their medications, and then we also have all of our team members to pop in and tell them how, what all services they have. A social worker, financial counselor. We tell them about our clergymen. We do have clergy present that can help you. Nutrition, that's a big thing. We have a nutritionist, a dietitian that's with us, and she sees the patients. So we do have a long visit like that with them. That's about an hour when they first start their treatment, a couple of days before.
Thank you. We're joined today with Tammy McManus, who's a patient nurse navigator, and also Dr. Alex Wilson, who's an oncologist with the Adena Cancer Center. If you want to ask them particular questions that you might have on your mind, or the discussion so far has generated some thoughts, by all means, please leave them in the box below. We do have staff that's ready on standby to get these questions to us. And actually, we do have a couple of questions that we'll take at this matter. So for Tammy, one of the questions are there any support groups that are still meeting, particularly through COVID?
Mm-hmm. At the present time, no, because of COVID. But I think whenever things, in the past we've had them, of course, and I think when things open up a little bit, they will meet again. They do virtually, I think, too. I just heard the other day that they have a virtual support program that you can log on to, and you know, if you have a need, just call me, and I can set you up through that. It's, through a couple of volunteers with the American Cancer Society, and they are going virtual now with that. So they did meet like monthly, and I'm sure they're probably trying to continue to do that virtually. It's usually in the evening, like one day a month.
And would you help the patient get connected to such groups?
Absolutely.
The next question that we have coming in is, are there patient navigators for each type of cancer, or is there just general?
No,
How does that
for
work?
each type, yeah. Yeah, my partner Ashley Gilbert and I deal with lung and prostate cancers, and as I mentioned earlier, there's another 2 navigators, Carrie North and Holly Hooks, that deal with the breast cancer and women's cancers, GYN type, gynecological. And then Gina Fields and Barbara Short have the GI, pancreatic, that includes, colorectal, stomach, anything that way. And Barbara particularly deals with lymphomas, your hematological cancers, and brain cancer.
Okay. Dr. Wilson, does nutrition play an important part in cancer treatment?
Yeah, nutrition is vital. Yeah, it's one of the cornerstones of things that I actually talk to patients about the most, hydration and nutrition. We're very fortunate to have a nutritionist at the Cancer Center that meets with our patients often weekly or more than once a week. In nutrition, what it does is it keeps your energy up as best it can be. It helps with healing. With any type of cancer treatment, there is some type of healing required, whether it be chemotherapy, surgery, or radiation therapy. So good amounts of protein help with healing. And it also just helps with nausea, general malaise as well. So nutrition is key. And then also exercise. Physical activity has been found recently to be key, particularly during chemotherapy. And we've been diligent about trying to remind our patients of this. We did have an in-person exercise program. We're working toward a virtual exercise program for our patients. So both of those are really important.
So I know that sometimes patients don't feel well from the treatments, and that really affects their appetite and their ability to get good nutrition. Does the nutritionist help to come up with some plans or a diet or perhaps a medication that would help them to feel better and get that nutrition?
Yes, she's a good liaison too, to help, between the patient and the physician if they need something special. And then she's just a good person to refer to for dietary issues, what things they should eat, what things they should avoid, depending on if you have nausea or diarrhea or sometimes constipation. And then we work with the physicians, and she also works with us navigators. If there's some kind of medication needed, then we can help with getting that resolved. She also works a lot with patients that have head and neck cancer and esophageal, that type thing, and they may have feeding tubes, and they'll have to have that in, throughout their treatment period. So she helps with their nutrition-based needs on their weight and that type of thing as to how much that they would need through the tube as far as your nutritional supplements.
Okay.
So she comes up with a plan for that.
Dr. Wilson, can you help us dispel I think there's a lot of misunderstanding that centers around the word hospice and the role it plays in cancer treatment. Can you? I'd love to hear your thoughts on when do you involve hospice? What does hospice mean, and what does it not mean?
So there are a few terms there that people throw around that get somewhat confused. One's palliative care. Palliative care is focused on symptom control. And a lot of times folks associate that with hospice. Hospice is a very separate entity. Palliative care focuses on nausea, pain, fatigue. Involvement of palliative care for a cancer patient can happen right at diagnosis. And patients can be helped, and we do provide palliative care, but it's even more specialized palliative care could be involved in diagnosis, which is often given by someone who's also a physician who's also trained in hospice, so it gets very confusing. A hospice patient is a patient who has a life-limiting condition and has a specified time or estimate of time that they may be living. And so it's end-of-life care. But it doesn't mean that you're not getting any medicines or any care. It means that you still get medicines, you still can get antibiotics often. It is very specific to the patient and to the hospice, what types of things that they provide, but it's a great service and it allows patients to live well in their home that may have a diagnosis that's life-limiting. And it's best to involve them as early as you know you don't want aggressive treatment for that condition. And so I agree, it's very difficult. These are very close distinctions. They're similar types of care with different goals. I think one of the misconceptions I often hear regarding hospice is that it may shorten your life, but that's not true as far as I know from all the medical literature and all the patients that I've seen. With cancer, if patients are on hospice, they tend to live well and live longer, and there's a lot of information that suggests that. There was a study that looked at palliative care early on, so that's symptom control early on in cancer treatment, and that actually showed patients live longer getting that palliative care and attention to those symptoms outside of any other type of treatments. And palliative care was almost as effective as chemotherapy, or was effective as many chemotherapies for those patients. So I think the point, or the overarching theme of this little discussion is that both hospice and palliative care are important parts of cancer treatment, and they need to be sought as soon as possible. Hospice is much more effective once you know you don't want to have any more treatment for some type of life-limiting illness. It's not giving up. You get all this help that comes in with you. They control your pain. They provide medicines. They provide support. They provide help with any types of advanced directive or any type of social services need. So it's a very valuable service. It's underutilized early on in someone's terminal illness. You can feel fine and be on hospice.
You know what I liked? I liked the word that you said, or the phrase that you said, Dr. Wilson, that it's not giving up. That it's not giving up. And I think that's an important distinction for our viewers to understand, that the discussion about hospice is a very normal discussion in many cases, and does not mean that the physician, the nurse navigator, or family members, or even the patient yourself is giving up. It actually, in many cases, from what I've seen from my medical experience, it improves actually the quality of care and the quality of life, which I think is very important to many of our viewers. We have another question coming in. So Dr. Wilson, I think I'll direct this one to you. If your family has a history of cancer, do you offer genetic testing and counseling? So perhaps we can take a pause here and say, when would you need that? And if you do, how does that work?
Yeah, so that's a pretty detailed process. We currently offer genetic counseling and testing for patients that have a medical condition that show a high risk for that. So if you yourself have that condition, or your family member has tested positive at the cancer center, we offer that. However, we can help facilitate you receiving genetic testing at another facility. The best way to approach that is to talk to your family doctor about that, talk to your surgeon if you have a surgical need, and talk to them about your family history, because and then that family history has to be taken, and then it has to kind of be assessed as far as if there's enough things there that may necessitate genetic testing. It's a very difficult decision to make as far as who should be tested and who shouldn't. There's a lot of criteria if your insurance will or will not pay for it. But we can help facilitate that. If there are questions about that, please contact the Cancer Center, because we can help you through that.
So it's important to know that you're not alone. You don't have to go through this by yourselves, and we have wonderful team members here can walk you through whether or not genetic testing or family testing would be an appropriate next step. Dr. Wilson, it is a Lung Cancer Awareness Month. So let's talk with our viewing audience here just a little bit about if someone should be diagnosed with lung cancer, what are some of the things that are available here at Adena Cancer Center to treat that?
So we have a pretty comprehensive lung cancer program. We do have a robotic thoracic surgeon, Dr. Adena, who's able to do the surgical part of the treatment, very well experienced, great surgeon, great guy. And then we also have all types of radiation for lung cancer. We have more conventional radiation that you give over 6 weeks with a very new technology called Rapid Arc through Varian Company, which is the standard company, the best company to make your machines.
And you can do that here at Adena.
Okay. And that's the most common technology currently used across the country. We also offer stereotactic body radiation therapy, which is very similar to CyberKnife. There's a lot of commercials about CyberKnife, so I tend to mention that. And that's a way to treat a very, very focused or pinpoint radiation on a very small lung cancer. And then we offer all types of chemotherapy, immunotherapy, biologic therapy. It depends on the lung cancer. You know, there's a very individualized approach for lung cancer nowadays, and so many of them are set off from molecular testing. And you may have a particular target on your lung cancer that we think drives it, and so then your doctor may use immunotherapy, which is a therapy that harnesses your immune system to fight the cancer. It kind of unhides your cancer from the immune system. And then we also have biologic therapies available if your tumor expresses that. So if your tumor is driven by a particular mutation, then it can match up to a drug. And so we can provide that drug for you. So it's very comprehensive. We offer nearly 100% of what a lung cancer patient would need at any stage.
So very complex, a lot of different options, which is why I think it's very valuable to have that team, right, and to work through that. So we've heard a lot of complexity about cancer, and we do know that there's a lot of, as you heard from Dr. Wilson, there's a lot of new technology, a lot of cutting edge, and that leads sometimes to something called a clinical trial. Tammy, help us to understand what clinical trial means, and how would that, particularly, what does that mean for the patient?
Okay. Well, our hospital is affiliated, as are about 14 other hospitals in the surrounding area, with the NCOR, which is it used to be the CCOP, which is Columbus Clinical Oncology Program, and now it's called the NCOR. NCI, help me out here, Dr. Wilson.
Community Oncology Research
That's it,
Program.
the Community Oncology Research Program. And through them, we are able to screen people for studies. We have a research nurse, Ray Seitz, that screens people as far as their eligibility. There are certain criteria, and if they meet that, then he talks with the physicians and the patient, and they come up on a treatment plan through that study. The studies are, they break them down into phase 1, 2, 3. Generally here, I think we mainly is phase 3 studies. They compare like the standard chemotherapy or radiation, whatever, with maybe a newer type, and come up, you know, they do like, it's almost like a roll of the dice, but as to what program you would go on and that type thing. It's, help me out again, it's like randomization, yes.
Okay.
And they go from there as to how they're treated.
So Tammy, does the patient have to give permission to be in a clinical
yes,
trial? Yes,
absolutely.
Okay.
Yeah, a consent has to be signed. The physician and with the clinical trials nurse would explain everything to the patient first, and then they would have to get a consent signed to.
Now Tammy, oftentimes when the word cancer is raised, obviously the patient's affected directly, but they're not the only ones affected, right? They have loved ones, families, friends that are also equally affected, at least from a social or emotional standpoint. Can you help us to understand what you do as a team to provide support to those loved ones?
Yeah, we really get to know the whole family. Sometimes, and by family I mean anybody that's with them. Sometimes it is a family member, sometimes they don't have family around and they have friends that are with them, and we try to include them in the treatment plan as far as how they can help, get the patient there and that type of thing, what type of things that they can do to help them as far as comfort measures and things like that, and just questions to be answered as to what to do, for the patient. And a lot of emotional support is what we give to everybody. A lot of it's just, like I said before, answering questions. Sometimes they won't catch everything the physician said, so we talk to both, with their permission, to both of them to see the best treatment plan for the patient and to help them get through it with the least amount of side effects and discomfort.
Yeah, that's so important, right? It's so important to include the family and
Absolutely.
friends in this journey that the patient is going through, because they have needs as well. As we're finishing up, Dr. Wilson, just a couple more questions. Can you tell us a little bit about the accreditation that the Cancer Center has, and where does it stand out in the landscape of cancer therapy in the region?
So we have a couple of accreditations. We have the Commission on Cancer Accreditation. We're a comprehensive community program, so because of the size, the number of patients that we treat, we have a few more requirements than some of the other cancer centers in our region, so we're a more comprehensive site. We also have, on the radiation side, the American College of Radiology, Radiation Oncology Accreditation. And so both of those just make us, kind of force us to make sure that all of our standards are within national guidelines, and that encompasses the pathology, where they look at the biopsy slides. It looks at radiology standards, where they look at the scans, both how chemotherapy and radiation are administered. And then the last thing we're part of is the American Society of Clinical Oncology Quality Training Program. We received a grant to be a part of that. And so we do have outside quality experts working with our team to make sure our quality's at the standard that we want it to be. And so as far as where we stand, as far as cancer services in the region, we do offer more cancer services at our cancer center than any other cancer center in South Central Ohio. We have more robust equipment from the radiation side. We do have more depth as far as our oncology services, and so we have more oncologists and we have more nurses, and we do have a big layer of support for people. And that's something that's been really important to me since I've been here, is to make sure that we have a good depth of support, so that any day that you come into the Cancer Center, there's people there to help you.
Is it just located in Chillicothe?
So we do have a second infusion location for chemotherapy and clinic that Dr. Shailaja Mani operates out of Fayette Memorial Hospital, and that's an affiliation with that hospital.
And that's in Washington Courthouse,
yep,
I believe.
in Washington Courthouse.
All right.
Right next to the hospital, and she's delivering chemotherapy, immunotherapy, biologic therapy, many of the things we talked about today, and many of the, if you see her in Washington Courthouse, she can bring your case to the tumor board we talked about, talk to all the doctors, move forward just in the same fashion as if you were seen here in Chillicothe. So yeah, we've also expanded down there.
Awesome. As we're finishing up, and the time goes by very quickly when we're having these conversations, Tammy, any last-minute thoughts that you would want to share with the viewers out there regarding patient navigation?
Just basically use your navigator to help you get through everything. Don't try to do it alone. If you have questions, don't hesitate to call. That's what we're there for. We give you our business cards, and we tell you, call us, because that way it cuts going through the phone tree. You can get directly to us. If it's a question I don't know, I'll find out the answer for you and call you back. And we usually I try to get back to them within the hour. So that's what's pretty unique about having a navigator. You can get an answer pretty quickly for whatever you need. And, use your navigator. Don't try to, if you have a question, I always tell them, no question is stupid. Everybody, all your questions I want to answer, and I want to be there for you and your family to help you through everything.
Thank you, Tammy.
You're welcome.
Before I give the last question to Dr. Wilson, who is an esteemed oncologist in the region, I do want to remind the viewers about our lung screening program here. Again, it's Saturday, November 21st from 8 a.m. to noon. If you're between 55 and 74, you have that 30-pack-year history that I mentioned, or you're a current smoker or have quit in the last 15 years, you qualify for that screening. If you meet that criteria, please call 740-542-5864. And if you don't remember the 5864 part, it's even easier. It's 542-LUNG. So again, it's 740-542-LUNG. And if November 21st doesn't work well for you, please still call that 542-LUNG number and talk with the representative who can help you schedule a date that would be best suited for you. Also want to remind our viewers that we'll be back again with Living Well on November 19th. We'll be discussing diabetes. So if you have an interest or you have family members or you want to learn more about diabetes, please join us at that time. So again, I'm going to leave the last question to our wonderful Dr. Wilson, who does a fantastic job here at the Adena Cancer Center. What's one of the last parting words that you would want to share with our viewers regarding Adena Cancer Center or oncology?
I think in general for the viewers, if you know, particularly with these COVID times and people not being out as much and not seeing their doctors as much, as frequently often, I think it's important to one, get back in and see your primary care doctor, get things attended to, particularly if you're having a symptom or a problem that's persistent. That way, if there is something more serious involved, like a cancer or anything that would require more aggressive intervention, that you caught it early and you dealt with it. And I think it's important that folks stay connected with their physicians during this time, because we don't want other parts of our health to be sacrificed because of our worry about the virus.
Please join me in thanking Dr. Alex Wilson, who's an oncologist and our medical director for Adena Cancer Center, and as well thanking Tammy McManus, who's a patient navigator at the Adena Cancer Center. And please join us again on November 19th for another wonderful edition of Living Well with Adena. Thank you very much.